Um, okay, so it is my real pleasure to introduce our two speakers for today. I will start with Dr. Alison Galvani, who is a great friend and longtime collaborator of me in the lab. I think the first time I met Alison in person was when she came to UT in around 2008 to give a departmental seminar, which was so eye-opening for me and really impressive. She talked about a fascinating study on prioritizing influenza vaccines and the tension between kind of the benefits to individuals and the benefits to the community as a whole, depending on who was prioritized. And at that time, our lab, which was just kind of in its very early stages, was really in the thick of developing these new tools, these new frameworks for network modeling of infectious diseases. And Alison and I really hit it off. We threw together a proposal for an NIH MIDAS grant. And at that time, this was the second round of MIDAS. For those of you who know what MIDAS is, at that time, the request for proposals was specifically looking for modelers who were going to dive deep in behavioral modeling, really think about how human behavior impacts the spread of diseases. So it was sort of a perfect match between our look at networks and Alison's look at decision-making and the economics of epidemics. And so here we are today, 12 plus years later, 5 collaborative grants later, really with, having collaborated on a lot of really interesting things. Dr. Galvani is just such an impressive scientist. She did her training at Oxford. She got both her bachelor's degree and her PhD there. Her advisor was Lord Robert May. For those of you who don't know who Lord Robert May was, he was a scientific advisor he was the scientific advisor to the British government, who's the president of the Royal Society. He's one of the fathers of modern epidemiology. He is one of the authors of the canonical Anderson and May textbook. And so she learned from one of the fathers of our field. After getting her degree, she spent some time at UCal Berkeley as a prestigious Miller postdoc, and she's been at Yale School of Public Health for her entire career. She's now a chaired professor. She has the Burnett and Stender Families Professorship. She has honorary positions at the University of Liberia, Kitt School of Public Health in India. She's won so many awards, including the Bellman and Blavatnik Award, Macmillan and Guggenheim Awards. And at Yale, she runs not only her lab, but the Center for Infectious Disease Modeling and Analysis. She does just groundbreaking, innovative work at the interface between epidemiology, ecology, and economics. And she's done work on influenza, TB, HPV, HIV, Ebola, and now COVID. And she is, I think, Tony Fauci's go-to for good science and rapid analysis around emerging threats. And she is truly one of my role models throughout my career, who I've had the great privilege to work with, and so happy to have today. We're also really pleased to have Dr. Abhishek Pandey here with us today. He is an associate research scientist at the center at SIDMA that Alison directs. He got his bachelor's degree in math from Ramjas College at Delhi University, his master's in applied math from Indian Institute of Technology in Roorkee, his PhD in math at Clemson University in the United States. And he focuses specifically on understanding the impacts of socio-political conflicts on public health response during disease outbreaks and evaluating control strategies for different kinds of diseases. He has first authored papers in Science on strategies for controlling Ebola. He's written papers on controlling sleeping sickness in Guinea and the elimination of trypanosomiasis. That was published in Lancet Global Health and has been a contributor in many other important papers coming out of their center. And I think today we're going to get to hear about Dr. Pandey and Dr. Galvani's work on COVID. So thanks again for being here, and the floor is yours.
Thank you so much, Lauren. That was the nicest introduction I've ever had by far, so thank you.
Yeah. Thanks so much, Lauren. Let me share my screen. Okay. So hope everyone can see my screen now. Yeah. So hi, everyone. Thanks for inviting us. And we are really happy for this opportunity to share some of our work that we have been doing on coronavirus at Center for Infectious Disease Modeling and Analysis. So back in January, when outbreak in China began spreading, and some cases were reported in travelers outside China, we began focusing our research on COVID-19 at Sigma. In our earliest work, we evaluated the impact of international travel on global spread of coronavirus. I think Lauren was part of that paper as well. This followed with some early work on assessing the hospital capacity in the United States. And more recently, we have looked into the contribution of asymptomatic and presymptomatic infections towards transmission. So what I'm going to do today is present some of our early work as well as some of the recent work that we have been doing at Sigma. So let me begin with a brief timeline of COVID-19 in the US, leading to the questions that we tried to address. So, I'm sure that everybody is familiar with it now, that the first case of COVID-19 in US was confirmed on January 21st in a man in his 30s from Washington state who developed symptoms after returning from Wuhan. 9 days later, first case of human-to-human transmission in US was reported on January 30th. A woman from Chicago who returned from China, her husband developed symptoms. On February 26th, CDC actually reported community spread. It confirmed that an infection in California that represented the first US person to contract the virus, despite not visiting a foreign country recently or coming in contact with any infected patient who may have returned from China. At this point, on February 26th, the number of COVID cases detected in the United States were only 15. 2 days later, on February 28th, it was known that test kits CDC had sent to states were flawed. CDC announced that it has taken steps to address these problems with the fraud kits. Until now, only limited testing was available, if we recall properly, and only through the CDC. So moreover, testing criteria restricted the testing to only individuals with known travel history and those with specific symptoms. So from this point onward, CDC expanded this criteria for coronavirus testing as well. The very next day, US reported its first death outside Seattle. Months later, autopsy findings revealed that 2 people had already died due to COVID-19 as early as February 5th or 6th, indicating that community transmission must have been occurring much earlier than it was believed at that point. In less than a month from then, of the first reported death, US surged past China and Italy to become world's most infected nation. We had most cases in the world. During this time, there was growing concern that the surge in number of cases will overwhelm the healthcare system. And more specifically, as it was being seen in New York at that time too. Weeks before the actual epidemic reached its peak in New York, on March 26th, according to the New York governor's office, there were only 307 ICU beds available in the city and just about 1,000 in the whole of New York State. Fortunately, urgent expansion in capacity along with stay-at-home orders enabled New York to avoid hitting the surge capacity. So in our early study, what we tried to do was to understand what the situation could look like throughout the United States. So to do that, we developed an age-structured mathematical model for COVID-19 transmission and parameterized it with the US demography. So the model compartments followed the natural history of the COVID-19 infection. So basically susceptible to exposed, and then after you're exposed, you either become symptomatic or mildly symptomatic, and you either actually isolate yourself or not isolate yourself, and then depending on your severity of the disease, you can go to hospital or ICU and so on. And we parameterize it the model compartments followed, as I said, natural history of the infection, and the rates were parameterized based on the best known estimates for the parameter that we could find from the literature at that time. So using the model, we calibrated our transmission model to the initial estimates of R0, which was the reproductive number back then. The best estimate was 2.5. And what we found was that at the epidemic peak, we estimated that around 290,000 people would be needing ICU beds, and most of them needing them would be above 50 years of age. this was 3 times more ICU beds than existing number in the whole of United States, which was close to 100,000. To be exact, it was 97,700 something. And if we accounted for the fact that not all these ICU beds are available all the time, in fact, 65% of these ICU beds are generally occupied in US at any given time. So accounting for that, what we found was the need would be even greater, in fact, 8.5 times higher. Using the same model in another paper, we also projected that at the peak of epidemic, we will require 40,000 additional ventilators that were available, as you can see in the the green histogram on the right. So then we simulated disease spread under a range of scenarios for self-isolation, because at that point, other than a stay-at-home order, self-isolation or isolating individuals was the main thing that you could do. So at this point, the point was that symptomatic individuals could self-isolate to reduce their contact within the community by staying at home. So what we found was that isolation of cases can ease the burden on the healthcare system, but it depended on what proportion of cases self-isolate and how fast they do it. So for example, if 20% of mildly symptomatic individuals who do not need hospitalization self-isolated themselves within 2 days of developing symptoms, the peak weekly requirement for ICU beds was reduced by 25%, and it was delayed by 4 weeks. Whereas if they self-isolated within 1 day, then the requirement at peak would be reduced by 50% and delayed by 12 weeks relative to the no self-isolation, as you see in the figure on the right. And you may notice that it still actually doesn't, our capacity still doesn't really, we are still above our capacity. However, probably the delay could provide you enough time to prepare for it. And that's why it was important. So as a summary, while our results were at national level, so they did not capture the important spatial heterogeneities, which is really very important. But many other papers later showed similar results at a more granular levels. Also, as we did not know much about pre-symptomatic and asymptomatic infections back then, our model did not account for them. However, to some extent, the proportions of mild infections who do not need hospitalization that we had actually incorporated accounted for some of the asymptomatics. Similarly, though including pre-symptomatic as we did in our later work could have potentially pushed the peak earlier as the infectivity of persons shifts. So at that time, our results still underscored the urgency of ICU capacity expansion, necessity of mitigation strategies that would accelerate case isolation, such as increasing testing, rapid contact tracing, and population level movement restrictions. States across the country were also racing to stockpile ventilators at that point, PPE and other medical supplies, as they were all preparing for surge in COVID cases in their respective states. So our results also highlighted the need of federal coordination on the production and distribution of PPE and ventilators across the states. In light of these growing concerns, most states had issued a stay-at-home directive by March 31st to encourage social distancing and flatten the curve. However, in late April and early May, socioeconomic repercussions fueled the call for reopening the economy and lifting the social distancing measures. During the month of May, many states began lifting stay-at-home orders and other restrictions on social and business activities that were put in place to curb the spread of COVID-19. And as expected, cases began surging again in several states, including Florida, Texas, and Arizona. At that point, US actually was reporting their highest daily number of cases, which was about 50,000 cases per day. While some of the states at this point began reconsidering the restrictions, it was still unsure if they will go back to the restrictions like before. Therefore, in the absence of population level restrictions, isolation of infected individuals remained the key to curtailing transmission. However, based on updated information or not, updated knowledge about asymptomatic and pre-symptomatic infections at that point, it became important to revisit the strategies which were based on symptom-based isolation alone. So that's what we did in our next analysis, or our most recent paper. So before I jump into that, let me see what knowledge that was updated, which we used to look into it. So in particular, one study estimated that about 18% of the COVID-19 cases on the Diamond Princess cruise ship were asymptomatic. Another study which used data on Japanese nationals, which was around 550 people who were evacuated from Wuhan, and there they estimated the asymptomatic ratio to be 30.8%. Now, these are the two numbers we have used. However, more recently, after our papers have been published, there are several other estimates of asymptomatic proportion. For example, a very recent paper in CID estimates asymptomatic proportion to be 23%. But as I said, I'm pointing these 18% and 31% particularly as these are the used in our numbers. But just to give the background information, this new study that actually puts this number to be 23%, they actually identified and hospitalized around 280 RT-PCR positive contacts of COVID-19 patients in China, and they found that 23% of them remained positive, remained non-symptomatic before they were discharged. So moving on to the information that we have about pre-symptomatic, by that time, empirical studies had showed that individuals may be most infectious during pre-symptomatic phase. In particular, a study that was published in Nature Medicine showing temporal patterns of viral shedding of 94 patients in China estimated the peak infectivity occurred prior to the symptom onset. Now again, this is what we have used. There is this was the original study. However, later they have published a correction to the original paper. In the corrected version, the incubation period that they had estimated is a bit longer. So it used to have in the original paper, the mean was about 5.2 days, and now it has shifted to 8.3 days. But infectivity just prior to symptom onset, even in the updated paper, remained substantial. So therefore, effectiveness of any symptom-based isolation strategy will be dependent on extent to which pre-symptomatic and asymptomatic infections contribute towards transmission. So in our most recent study, we translated this clinical level data on infectiousness and symptoms to population level epidemiological impact. To do so, we extended our previous model to include asymptomatic infections and the pre-symptomatic stage, parameterized with the data regarding the trajectory of symptom onset and the proportion of secondary cases generated in each stage of infection. And here is what we found. So if 17.9% of the infections are asymptomatic, the pre-symptomatic stage accounted for 48% of the transmission, and asymptomatic infections accounted for 3.4% of the transmission. If we took the greater asymptomatic proportion of 30.8%, the pre-symptomatic phase and asymptomatic infections accounted for 47% and 6.6% of the transmission respectively. More importantly, what we found was that even immediate isolation of all symptomatic cases, as you see in the blue lines in here, in both the figures, even if we actually do immediate isolation of all symptomatic cases, it was insufficient to achieve control. Specifically, the mean attack rates remained above 25% of the population when 17.9% of infections are asymptomatic, and above 28% when 30.8% of infections are asymptomatic. Now, our results also corroborated the contact tracing studies that had indicated substantial role of pre-symptomatic transmission among around 250 cases in Singapore and around 450 cases in China. So given this knowledge, what we did next was that Given the inadequacy of symptom-based isolation to control the outbreaks, we considered synergistic impact of isolation for pre-symptomatic and asymptomatic infections. So combined with case isolation, perfect case isolation, in fact, our results indicated that we'll need to have 33% and 42% detection and isolation of these silent infections to suppress the attack rate below 1% for asymptomatic proportion of 17.9% and 30.8% respectively, which like, easier said than done, of course. So as a summary, what this paper of ours did and highlighted is that it had several takeaways. First of all, that silent disease transmission was responsible for more than 50% of the overall attack rate, and it being capable of sustaining outbreak alone, even if all the symptomatic cases are immediately isolated. And this makes the control of COVID-19 even more challenging. It indicated that symptom-based interventions would not be sufficient to curtail the transmission. Of course, it highlighted the urgent need of scaling up testing of suspected cases without symptoms, which means that we will need to identify exposed individuals prior to their infectious period, infectious period. And so symptom-based surveillance must be supplemented by rapid contact-based surveillance. And it is also worth noting, finally, that our estimates here are actually our estimation for isolation of silently infected trans individuals are conservative for various reasons. For example, the inevitable imperfections in isolating symptomatic cases would translate into a greater need to prevent silent transmission, because for this we assumed everybody who is symptomatic will be isolated immediately, which is not really going to be perfectly executed ever. So the need to isolate more asymptomatic and pre-symptomatic individual becomes even more greater. Similarly, delays in contact tracing would increase the risk of onward transmission, especially since those without symptoms are generally unaware of their infection risks to others, therefore are less likely to restrict their social interaction. And in fact, if you go by how things are, even people after knowing that they are positive, some of them are not as careful as long as they are asymptomatic, as was seen in University of Chicago problem, where they opened it and they say that the students who had got positive test, they kept actually going to the parties, and it resulted in many cases there, even after they being prepared a lot by having all the students going through 2 tests every week, and they had to show some some evidence of testing negative before entering the school buildings. Even after that, the students who were tested positive had positive results. They also went to parties, and that resulted in cases. Anyway, so coming back to this, at last I would like to say that our results are pertinent in highlighting why we need to aggressively expand testing to people without symptoms, do rapid contact tracing and isolation, and complement it all by other measures, including continuing the social distancing, as well as making widespread use of testing affordable and possible. And as we are talking these days in the United States with about cheap test of $5 and so. And that's all we have for you guys. Thanks so much for listening, and I'd be happy to answer any questions.